Hi everybody, welcome to the latest in our MAHSC lecture series. So today we have a couple of speakers going to introduce their MAHSC inaugural lectures. So I'm going to hand over to Phil Cower to introduce our first speaker today. Thank you, Phil.
Thanks very much, Pete. Yeah, it's a real pleasure to be able to introduce Professor Dimitris Poulikakos, who I've worked with for many years actually. So I'm Phil Cower. I'm a nephrologist working at Salford Royal Northern Care Alliance. So Dimitris qualified as a doctor in Athens in 1998. He undertook renal training, I believe, in London largely, and completed his MD in 2015. Actually became consultant with us. It was a pleasure for him to move up north. Joined us in 2014, and actually has been our clinical director and has done great things at the renal service of the Northern Care Alliance since 2023. So, as well as those sort of functions in clinical medicine, he's been the Northwest Kidney Network director, I think still is for our Northwest region. He's done innovative work in protecting our dialysis and transplant patients, really importantly during the COVID epidemic, and that led to quite a few important publications, as well as just a modification of our treatment pathways. But Dimitris is really well known for his interest in sudden cardiac death, which is a really big problem in our dialysis population in particular. And his MD thesis was basically based around computerized electrocardiographic risk stratification of patients with sudden cardiac death. I'm sure we'll be hearing about that very shortly. In addition, he's an expert in AKI, and one really magnificent string to his bow was that we've been sister center to a center in Nigeria, and we've really helped develop their renal services, which were absolutely non-existent. And Dimitris, I think, had visits over there and has played a key role in developing that. So he's done a lot, and this awarding of a MAHSC chair is absolutely, well deserved. So Dimitris, it's a real pleasure to ask you to go ahead and speak now, please.
Oh, thank you very much, Phil, for the generous introduction. It is a great honor to present this inaugural lecture, and I would like to begin by sincerely thanking the University of Manchester and the Manchester Academic Health Science Centre for awarding me this chair, and I'm deeply grateful for this recognition. So I'm very conscious that I stand here today representing the efforts of many colleagues who have influenced this work. Academic medicine is not a solitary field, and career progression is rarely a straight line. It's an uncertainty and a journey. So at the start of sharing my journey, I would like to acknowledge two people who shaped my decision to pursue nephrology. That's Christos Douliarakis, very good friend and nephrologist from Greece, who convinced me that this was simply the right specialty, and Nikolaos Papagalanis, who was director of nephrology at the Red Cross Hospital in Athens, a truly inspiring nephrologist and teacher who used to organize unique renal conferences on the beautiful island of Kythera, which is depicted in the background of this first slide. It was many years later that I found myself at St. George's Hospital in London, where my academic journey began. So at St. George's, I pursued a doctoral on computerized electrocardiography for risk stratification for sudden cardiac death under the mentorship of Debashis Banerjee. My research started with a clinical problem, which was sudden cardiac death in dialysis patients. And at the time, and still today, it represented one of the greatest challenges in nephrology. And this because despite major technological and scientific advances, outcomes in dialysis remain strikingly poor. Only around 50% of patients are alive 3 years after a dialysis initiation, with cardiovascular disease and sudden cardiac death being the leading cause of death. I managed to recover this slide I presented approximately 14 years ago at St. George's, comparing outcomes over the previous decade. And at that time, we were happy by substantial reductions, almost by 50% since the 90s, in mortality following MI and stroke, reflecting major advances during that decade in cardiovascular care. However, during the same period, as you can see, rates of sudden cardiac death had remained unchanged at approximately 26%. And tools that had transformed cardiovascular medicine in the general population simply did not work well in sudden cardiac death in dialysis patients. And what was particularly frustrating was that we had no ability to identify which patients were at highest risk, and this was the main question of our research, hoping that if we could answer this question, we would explore preventative intervention. So at the same time, I was fortunate to work with another extraordinary mentor, Professor Marek Malek, one of the world's leading authorities in computerized cardiac electrophysiology. And I found his work and main concept immediately fascinating. Computational analysis of the raw ECG digital signal offered a way of interrogating and quantifying the hidden dimensions of the cardiac electrical signal, which were invisible to the naked human eye. Some of those novel markers of invisible electrocardiography had already shown good predictive value in cardiac populations. On the right, selected ECG markers are presented, such as the QRST angle on top that represents the angle between repolarization and depolarization following three-dimensional reconstruction of the ECG signal, to represent the electrical activity as a moving vector in space, and heart rate variability in the frequency domain on bottom. Our first task was methodological. Could these measurements be trusted in dialysis patients? Were they stable and reproducible in those patients whose electrolyte and fluid status fluctuate between treatments? And the answer was yes. In the study we performed in 80 patients followed up with intradialytic Holter ECGs, continuous recordings, every other week for 3 months. The next chapter of my career brought me to Salford Royal as a consultant nephrologist, and at that time Salford was a very distinctive place. It was a leading cardiovascular research center for chronic kidney disease under Professor Calra's leadership, and at the same time the trust was enjoying national recognition for clinical excellence. It was ranked first best in the country and was designated as a digital exemplar. Most remarkably, this organization delivered these outcomes despite serving one of England's most socially deprived populations, which was both inspiring and fascinating to me. It also represented an opportunity to test whether the signals we had identified in the St. George's study, that were unpublished at that stage and are depicted on the slide on the top right figure for QRST angle, could be replicated in a larger dialysis population at Salford that already had an accumulated database of digital ECGs. And we did manage to secure a Kidney Research UK grant in 2015. This work subsequently was undertaken as part of Dr. Sofia Scabartoni's PhD and confirmed that an increased QRST angle was independently associated with adverse cardiovascular outcomes. That's the figure on the right. Around the same time, an independent group in the United States, led by Larissa Teresenko, investigating a larger cohort of incident dialysis patients, reported similar findings for QRST angle, providing further confidence that we were observing a genuine biological signal rather than a chance association. However, as often happens in research, just one question appeared to be answered, several new questions emerged. A series of studies using implantable loop recorders have begun to challenge the assumption that the underlying rhythm for sudden cardiac death was ventricular tachycardia or fibrillation. 5 INLAR studies suggested that bradyarrhythmias, rather than ventricular arrhythmias account for the majority of the sudden cardiac death, summarized on the table on the right. However, these studies, despite admittedly being heroic in nature, were relatively small, included highly selected patient populations, and were constrained by the technological limitations of the ILR technology, including high false positive detection rates of bradyarrhythmias and limited storage capacity. Near the same time, another heroic negative study with ICDs for primary prevention in dialysis patients with preserved ejection fraction had showed prevalence of ventricular tachycardia and fibrillation to more than 10% of the patient's recruitment. So very important questions were raised. So what is the relative contributions of bradyarrhythmias or ventricular arrhythmias in sudden cardiac deaths? How should we respond to the high burden of atrial fibrillation detected through continuous monitoring? And these became major questions in the UK Cardiorenal Clinical Study Group, and I started leading the arrhythmia in dialysis workstream in 2020. Our ambition was to develop a staged multi-center research program, the first phase focusing on evaluating emerging technologies for continuous monitoring. The second phase seek to define associations of terminal arrhythms and ECG profiles, and ultimately, if these stages were successful, the goal was to design a large multi-center interventional study. Well, of course, not every step of that journey has been successful. We have submitted ambitious grant applications but have not been successful yet. In early 2020, I was appointed Clinical Director of Renal Services at Salford, just weeks before the pandemic was declared. Early reports suggested that patients receiving in-center hemodialysis faced an exceptionally high risk of death because treatment required frequent visits, often shared transport and close proximity. Dialysis could not simply paused or moved online. At that stage, however, official guidance was slow to recognize airborne transmission, and early requests for enhanced precautions were rejected due to insufficient evidence. And this was a defining leadership challenge. We were faced with two urgent questions. First, how could we reconfigure our services rapidly enough to protect our vulnerable population while maintaining life-sustaining treatment? And second, how could we generate the real-world evidence needed to inform policy and influence decision makers when traditional research timelines were too slow for the pace of the crisis? And I was fortunate to be part of an extraordinary team at Salford that rose to this challenge and responded decisively to both questions. And I remain deeply grateful to all of them. Almost overnight, priorities changed, clinical services were reorganized, resources redirected, research was focused on urgent questions to formulate immediate responses. On the left, within a few months of the first lockdown, we published two studies. One examined antibody prevalence among healthcare workers, with participation from almost every member of our department, and the second evaluated infection risk among our hemodialysis nurses. Both suggested that the recommended level of personal protective equipment was insufficient for renal settings, and informed revised national guidance recommending enhanced PPE later on. Alongside this research on the right, the quality improvement program led by Rosie Don led to elimination of outbreaks and contributed again to revised national recommendations for a bundle IPC approach. In less than 18 months, consultants, residents, nurses, pharmacists, administrative staff contributed to 11 peer-reviewed publications addressing key challenges during the pandemic, some of which are shown in this slide. And they included understanding antibody prevalence, vaccine immune responses in different patient groups, evaluating public health interventions, improving disease surveillance, and addressing vaccine hesitancy, particularly credit is due to Rachel Middleton for the transplant program, to Ed O'Riordan for the vaccination program, and James Dollett for the dialysis program, alongside many other colleagues who made vital contributions. Our unit achieved the lowest COVID-19 mortality rates among hemodialysis patients in the region, and exceptionally high vaccination uptake, and was shortlisted for the HSJ Patient Safety Award. For me, the enduring lesson was about the power of collective intelligence, shared purpose, and solidarity. The experience demonstrated how clinical services and research can work hand in hand. And as the pandemic subsided, attention returned to the long-term challenges facing kidney care. The pandemic exposed and intensified existing problems, such as widening social inequalities, rising chronic kidney disease prevalence, growing numbers of patients requiring dialysis, and so on. As clinical director and later co-chair of the Northwest Kidney Network, I had the privilege of working with outstanding colleagues across the region and to collaborate closely with our network manager, Vicky Ashworth, and my friend and co-chair, Ash Sharma, supporting the renal transformation program across the Northwest. At Salford in NCA, we have tried to align service transformation, research, and innovation as complementary priorities. Through the Donald O'Donoghue Research Centre, led by Professor Kalra, we expanded research active consultant roles, increased opportunities for clinical research fellows, and strengthened the integration of research into routine care. Inevitably, my research interest expanded beyond disease mechanisms to focus on patient pathways, service innovation, and barriers to engagement with treatment and health inequalities. Now, looking beyond the UK provides an important perspective on health inequalities. In large parts of Africa, as you probably know, access to dialysis is extremely limited, and kidney disease, whether acute or chronic, often leads to death. I have been fortunate to participate in a long-standing collaboration supported by the International Society of Nephrology, working closely with good friends and colleagues, including David Lewis and Ibi Rekosima. Through this collaboration, last year we completed and reported on a 3-stage program of research into community-acquired AKI initiated prior to the COVID-19 pandemic. The program demonstrated that AKI is highly prevalent in children presenting with malaria to community healthcare centers, highlighting the need for further research to incorporate KEDAICO AKI criteria into the WHO malaria guidance. Malaria remains a major global health challenge, with over 2/3 of the 600,000 deaths reported in 2020 occurring in children under 5 in sub-Saharan Africa. A planned next step in collaboration with the Malaria Consortium was under development. However, changes in the US administration priorities and associated funding streams have delayed progress for now, with even more critical initiatives, I have to admit, such as the malaria vaccination program, also being placed at risk. Returning to settings where dialysis is available, the picture remains challenging. Sudden cardiac death remains a major cause of mortality in patients receiving dialysis. Registered data from the state suggests that this burden may even be increasing on the right. Our current work is focused on 3 main areas. First, we are defining the epidemiology and clinical phenotype of sudden cardiac death in our dialysis population since 2014. Second, we are investigating potential mechanistic pathways, particularly the role of inflammation and biomarkers such as FGF23, in order to understand disease biology. And third, we are undertaking a large-scale computational ECG analysis in collaboration with Professor Marek Malek at Imperial College, analyzing all historical digital ECGs in our hospital system. The project has been enabled by machine learning technologies to support efficient verification of ECG waveforms prior to computerized analysis, which in the past represented a major financial and time-consuming obstacle. The results are expected to be reported in 2027. Looking forward, the vision is to move towards integrated, scalable risk prediction that should enable a shift from retrospective observation to precision prevention, supporting targeted deployment of therapies and devices such as ICDs and pacemakers, and hopefully informing new mechanistic treatments for uremic cardiomyopathy. So as I mentioned from the start, the work I have described today reflects the collective contributions of mentors and colleagues. I have been truly privileged to work alongside extraordinary people throughout my career, and I remain deeply grateful to all of them, as well as to the many institutions and funding bodies that have supported this work. And most importantly, I would like to thank my family for sharing this journey with me, Mariana for her love, support and patience, and my children, Yanis and Electra, for the joy, laughter and sunshine that they bring into my life. And finally, I dedicate this lecture to my mother, Irini. Though she's many miles away in Athens, she's always close to my heart. Her love, sacrifices and her constant belief in me have shaped who I am, and for that I'm deeply grateful. Thank you very much, and I'm happy to take any questions.
So thanks very much indeed. What a lovely presentation. Thank you, Dimitris. So I'll obviously I've worked.
Shall I stop sharing?
Yes, why not? Why not? It's a beautiful picture there. We'd all like to go there now, the moment. But I'm happy to throw this open for questions from the audience. I mean, I obviously could easily ask you a few, but do people want to ask Dimitris any questions? We've got about 6 or 7 minutes. But
Yes.
in the meantime, Dimitris, so whilst we're waiting then, please put your hands up, by the way, if you'd like to ask. Just will you just define SCD, sudden cardiac death, for everyone, because they may not be quite so familiar as we are, really, just in it. Do you mind?
Yeah, so this is a critical point, Phil. So in the dialysis population context, which is a pragmatic approach of defining sudden cardiac death, is sudden unexpected death with no alternative etiology when the patient was seen well 24 to 48 hours of the last dialysis session, because they dialyze every other week. Strictly speaking, the narrow definition obviously is sudden death that should be attributed to arrhythmia occurring within hours, but we have to have a pragmatic approach for this population.
Okay, thank you. And the other thing, again, whilst people are thinking, you mentioned FGF23, fibroblast factor 23, that again many people may not have come across. Do you want to just say a little bit more about that, because it is important in renal medicine, isn't it?
Yeah, so it is important in renal medicine. It is a hormone that is regulated by phosphate, and gradually the phosphate is excreted by the kidneys. As many people know, as chronic kidney disease evolves, it starts accumulating, and as a response FGF23, that's when AXE starts increasing. There is some experimental evidence that it might be contributing to uremic cardiomyopathy. It is a controversial area, however, so there are other groups that confirm and other groups that do not confirm this finding, but it's definitely a molecule of interest in relation to the what we call uremic cardiomyopathy, which is it is a particular phenotype of cardiac disease in dialysis patients that is not following the traditional ischemic cardiomyopathy phenotype and does not respond to treatment for ischemic cardiomyopathy the way that ischemic cardiomyopathy does.
Oh, thank you. So any questions from anyone else? Just maybe you might have been interested in, Dimitris's discussion about Nigeria, for example. Lots of great work there. You mentioned that things are paused at the moment there. That's disappointing. That AKI work, the anti-malarial work, is that just a reflection on what's going on across the Atlantic and whatever? What's going on?
Yeah, we had a really ambitious program lined up from that. So 1 in 2 children presenting with malaria in a community setting had AKI. So that was a striking report. So we had a plan together with the Malaria Consortium to do a prospective study on this and then perhaps inform or contribute to inform the malaria guidance. But then the administration changed and I think the malaria, quite a lot of the work, the existing work stream of the Malaria Consortium have paused. So I wouldn't be optimistic at this stage that this is going to be reinstated.
It's a real shame. So Professor McLaughlin, John?
Thanks, Dimitris. I really enjoyed that. Early on in the talk, you talked about in COVID having a very high vaccine uptake in Salford. And I'm sorry if I missed it. I was wondering how you achieved that. What the barriers and facilitators were for achieving high vaccination levels.
Yeah, absolutely. So we had a publication dedicated to that. So we had a strategy to address vaccine hesitancy in addition to the general educational programs, and that was based on what we call trusted messengers. So we figured out that there are specific individuals within our service that have established good relationships and trusted relationships with the patient. So when we had vaccine hesitancy, it was these individuals that would take over to explain rather than having a generic approach, speak with your GP and so on. And we were monitoring this very closely, and we were adjusting our approach. Another thing that was extremely helpful, and that was, I have to say, Ed O'Riordan's idea, was that we analyzed results about the vaccines within our unit, and then we had posters saying this is what happened following that was the very beginning. And that was really well received from patients saying this is what happened, at my unit or at the other unit. So there were several techniques, but I think the main approach was the approach of the trusted messengers coming close.
Great, thank you. We're almost time to switch over to John introducing Javed, but just one last very, very quick question. Great work in this, the computerized electrophysiology and everything, and thinking of our Greater Manchester BRC, obviously really importantly, which you'll be part of course. How do you think you can take this forward into big grants? Is it a potential, BHF, etc.?
Yeah, absolutely. I think that was with some relative certainty will be the next step. We should be having results over the next 6 months, and I'm sure the next step is a large grant in relation to this one.
It'd be nice to see that. Yeah, thank you. Okay, thank you very much indeed, Dimitris. Excellent talk and discussion. I think it's over to John straight away now. Thank you.
Thanks, Phil.